Vesicoureteral reflux, etiology and epidemiology. Vesicoureteral reflux, VUR, is retrograde flow of urine from the bladder to the ureter or kidney. Primary VUR is the most common form and results from a congenitally short segment of ureter within the bladder wall, which does not get fully compressed by the contracting bladder muscle during voiding. VUR is the most common anatomic abnormality found in infants and young children with febrile urinary tract infection, UTI. There is a genetic predisposition to primary VUR with an increased risk in children with affected parents or siblings. Secondary VUR may be present in children with other urinary tract anomalies. In children with ureteral duplication, VUR is commonly seen into the ureter draining the lower pole of the kidney. VUR is seen in up to 50% of children with neurogenic bladder. VUR may also be seen in children with increased intravesicular pressure due to bladder outlet obstruction, e.g. posterior urethral valves.
Belly syndrome. Clinical manifestations. The most common clinical manifestation of VUR is febrile UTI. See Chapter 114. Recurrent febrile UTI is more likely in children with higher grade VUR. Reflux nephropathy involves development of renal scarring in a child with VUR and recurrent febrile UTI. This complication is more likely in children with higher grade VUR and more frequent infections. Renal scarring is not always visible on RUS and is best identified by nuclear renal scanning. Diagnostic studies. Renal ultrasound, RUS, is typically obtained first to evaluate the kidneys and urinary tract. While the findings of renal and urinary tract anomalies make VUR more likely, the absence of these anomalies does not rule out VUR. Therefore, avoiding cystourethrogram, VCUG, is required to confirm the diagnosis of VUR in a child with recurrent febrile UTI. An international grading system based on VCUG imaging is useful to describe the severity of reflux.
Complex clinical circumstances. In children with a normal RUS, a VCUG is recommended after the second febrile UTI. Management. Grades 1 and 2 primary VUR will likely self-resolve as the intravesical ureteral segment lengthens with growth. Many cases of grades 3 and 4 primary VUR resolve when VUR is diagnosed before 2 years of age and is unilateral. Severe, grade 5, primary VUR and secondary VUR are less likely to resolve spontaneously. Management options for a child with VUR include surveillance, medical therapy, and surgical intervention, but there is lack of consensus on when these options are indicated. In children with low-grade VUR, a surveillance approach with early evaluation for febrile UTI may be considered. Antibiotic prophylaxis may benefit children with moderate to high-grade VUR and/or recurrent UTI. While there is evidence that antibiotic prophylaxis reduces UTI frequency, its benefit in preventing renal scarring is less proven. Children with VUR should be monitored for bowel and bladder dysfunction, as its medical treatment may facilitate resolution of VUR. Indications for surgical intervention include VUR that does not resolve over time or is complicated by recurrent febrile UTI despite medical therapy. Children with VUR and recurrent UTI should be monitored for evidence of CKD, including poor growth, hypertension, and proteinuria.